Yes, Dr. Usha.
Yes, sir. So, a very good afternoon to all. The scientific committee of the 23rd IPS wanted to have topic that would clarify concepts and form strong foundation for our PG students in particular and all prostho in general. Edentulism and its impact on airway is one such topic that is continuously evolving with time. It is a great pleasure to have Dr. Brig Mahesh Gowda, who also throw more light. So, sir, please throw more light on it. To chair this session, we have Mr. Vikas Patel and Maninder Hundal. So, Dr. Vikas Patel has completed BDS and MDS from Government Dental College, Ahmedabad, and is currently Associate Dean, Professor, and Head of Department, Department of Prosthodontics as Nursing by Patel Dental College Hospital, Visnagar. She also has numerous publications to her credit. Dr. Maninder Hundal is currently serving as the Executive Officer in the Indian Naval Dental Center at Mumbai, which is Institute of Indian Armed Forces. She has been awarded numerous awards by the Indian Army as well as the Indian Navy for her meritorious work in serving the organization in both field as well as peace establishment. She did her BDS from Government Dental College, Amritsar, and MDS in Prosthodontics from Armed Forces Medical College, Pune, Mumbai. She has numerous scientific papers and publications to her credit. She is also an affiliate faculty for the postgraduate resident of prosthodontics at the Army Dental Center Referral and Research, New Delhi, as well as the Armed Forces Medical College, Pune, India. Over to you, ma'am.
Thank you so very much for having invited me to chair this session. It is indeed a pleasure for me to sort of introduce Brigadier E. Mahesh Gowda, who is my senior both in service as well as in specialty. Brigadier Mahesh Gowda is an alumnus of Government Dental College, Bangalore. He completed his BDS in 1990 and was commissioned in the Indian Army in 1991. He completed his MDS in prosthodontics from the Armed Forces Medical College, Pune, Mumbai University in 1998. He is a recognized postgraduate teacher for MUHS Nasik as well as Delhi University. Presently, Brigadier Gowda is posted as Commandant and Command Dental Advisor at Command Military Dental Center, Southwestern Command, Jaipur. In his 30 years of service career, Sir has served in various places all over the country, including a foreign tenure and other prestigious institutions of Indian Army. He is a recipient of G.C. Das Award for Best Scientific Paper Presentation. And it is to his credit that he has nearly 57 national and international publications and many scientific deliberations as a guest speaker. His areas of interest are maxillofacial prosthodontics and upper airway disorders in Edentulous patients. Brigadier Gowda also holds a degree in hospital administration and a certificate course on implant dentistry. Today, he shall be throwing light on the topic of edentulism and its impact on airway. So I, on behalf of the organizing committee, as well as my co-chairperson, Dr. Vilas Patel, would request Brigadier Gowda to please start with the scientific deliberation. Over to you, sir.
Good afternoon, ladies and gentlemen. Thank you very much, Chairperson, for the warm introduction. At the outset, I thank the organizing committee, the organizing secretary, Dr. Narendra Padiyar, for giving me an opportunity to share a little knowledge, what I have acquired over the years in the field of sleep dentistry. The topic per se is the edentulism and its impact on the airway. I always feel privileged to display my college photographs, both where I did my undergraduation and post-graduation. And I am indebted always to my teachers and the seniors for guiding me and training me with unstinted support. We are all noticed that snoring is one of the most common sign and symptom which can cause an havoc in the family life. Also, it is also involved with the other comorbidities like diabetes, hypertension, cardiovascular diseases, obesity, impotence. There are various causes which has been linked with the obstructive sleep apnea or the airway disorders. How to overcome this? Either we use a continuous positive air pressure appliance, or we use the oral appliances within its permissible physiological limit or the aspects. Over the last 3 decades, we, the dental surgeon or the dental fraternity, has gone into the issues with the airway and has found the potential causes, since we deal with the oral cavity, and a branch of dental sleep medicine has been evolved. As I told earlier, the sleep disorders or the obstructive sleep apneas have been responsible for the various other factors which causes potential harm both in the cognitive and the functional aspects of the individual, more say in the elderly individuals. Initial days, there were many known knowns, there were many known unknowns, and there are still many unknown unknowns in the field of airway disorders. With the consensus and collaborative learning of the many decades, many unknown issues have become unknown knowns. And with this unknown knowns, we could actually plan a comprehensive and a definitive treatment for the airway disorders. Tooth loss or edentulism, which can be either the partial or the complete, is a known factor. It is all accepted literature that it is the most common disease which is predominantly affecting the elderly population, irrespective of the nationality, race, or color. We also, studies have shown that the 45% of the above 65 years individuals have a difficulty in the onset of sleep and also the maintenance of sleep. So in total, almost 60% or about to 60% elderly report of daytime drowsiness, which is one of the most common feature of the airway disorders. The prevalence of teeth, we just said that lots of studies have been done about the incidence on the epidemiology of the oral loss or the edentulism, oral teeth loss. The incidence comes approximately around 20 to 21%. The other study by Mohammed Al-Rafi says that it is around 18%. It is an established fact that the edentulism has led into the obstructive sleep disorders, and we also know that it is not only the sleep loss, we also the loss of teeth. There is also deterioration in the quality of life, which we all know that, and life becomes restricted. There is a loss of self-esteem. There is a lower social status and deterioration in function. Now, it is not only the psychological and the physiological aspect of edentulism, which we all have read during the postgraduate days. It is also more to it. There is a cognitive dysfunction. It is also knows that the mastication or the chewing efficiency maintains the function of the hippocampus, which is the most important area in the brain which is associated with the learning and the memory pattern. And this hypothalamic pituitary adrenal axis, the stimulation contributes to the preservation of the cognitive maintenance. In fact, the Indian author Somajit Bagchi has also done a study between the hypothesis between the obstructive sleep apnea and the cognitive dysfunction. And among the 315 complete Edentulous patients using the mandibular advancing devices, he found out that there is a positive effect on the severity of the obstructive sleep apnea and the percentage of the cognitive dysfunction. The conclusion of his study says that the severity of the OSA and the neurocognitive dysfunction has tremendously or significantly improved with the patient who are rehabilitated with the complete denture. So that shows that the neurocognitive dysfunction can be prevented or reduced by just treating the patient with the complete dentures. The hypothesis, what the hypothetical pathway was, they say it is interrelated. If there is obstructive sleep apnea, it leads into a neurological disorder, and if there is a neurological disorder, it leads into obstructive sleep apnea. The pathway, what he says is, in case if there is a sleep apnea, there is a intermittent hypoxia, which we all know that, which leads into a cerebral hypoxia, which there is an insult on the hypoxemic ischemic insult to the brain, although maybe in a short duration, which leads into a perinatal brain injury. That leads into the maintenance of the failure to maintain the hemostasis and leads into neurological dysfunction to the neurological disorder. And vice versa, this leads into a reduced ventilatory control during sleep, which leads into reduced or a decreased unioglossal control and falling of the hypoglossal or the tongue muscles falling back and the pharyngeal collapse during sleep, which leads into a obstructive sleep apnea. There is lots of the exact cause which is still to be known. As in the future of my talk, I'm going to let you know about the various methodologies or various factors which is related to the obstructive sleep apnea and the neurological disorder. The latest or the one of the hypotheses is the oxidative stress. Oxidative stress is there is evidence which is implicate that the apneic related activities or the cycles of hypoxia leads to the formation of the reactive oxygen in the species, thus inducing the oxidative stress, which can be one of the cause for the obstructive sleep apnea and the comorbidities with these sleep disorders. So treatment of the tooth loss is important. We all know that as a prosthodontist. In several ways, receiving the prosthodontic treatment for the tooth loss signifies or improves the quality of life and brings back to the normal lifestyle. Now, if there is a tooth loss and the obstructive sleep apnea, whether there is any truth behind this two association or it is only a myth. Now, for this to explain, which is crux of my talk, we can talk in three aspects like Edentulism and the OSA. Is there any anatomic association or the correlation? And what are the sleep studies which has been undertaken in the upper airway analysis of the Edentulous patient? It can be a partial or the complete Edentulous patient. And ultimately, how to manage this OSA patients. Now, coming to Edentulism and the OSA, we can understand this association through the reverse engineering. We all know that during sleeping, there is a relaxation of the musculature of the oral musculature. The genioglossus, tensor veli palatini, and the other muscles of the airway becomes patent or relaxed. The mandible, due to the gravity, moves posteriorly, as does the tongue. There is a decrease in the upper airway volume, and thus there is a decrease in the oxygen of the blood level or the oxygen saturation, which in turn leads to the central reflex of the stimulation. So that leads into the increase in the respiratory muscular contraction, and the air is sucked in with the increased velocity through the negative pressure which is created by the diaphragm, and thus leads into a vibration of the soft palate and the uvula. So this is the basic fundamental how the snoring occurs. And ladies and gentlemen, I want to make it very clear that all snorers are not a OSA patient, but all OSA patients are snorers. The basics of the airway dynamics are the three things, which Venturi effect. This is a basic physics where there is a reduced diameter of the airways and the air is sucked in the increased velocity. It's like a balloon which when we do in the childhood, we used to blow the balloon and hold it with the elastic stretch one where it will make noise. That is the similar aspect. And the Bernoulli's principle, again it's a physics. There's an increased flow because of the increased negative pressure at the periphery. And the concept of the varial resistor. I don't want to go into the much details of the basics of the airway dynamics because this is not the purview of my topics, because we generally want to deal with the prosthetic aspect of the airway here. We all know that there is a functional impairment and structural changes as a consequence of edentulism. as a postgraduate student and the prosthodontist, going to be a prosthodontist, we all know that there is a decrease in the vertical dimension of occlusion, there is a change in the position of the mandible, there is a change in the position of the hyoid bone, and there is also impaired function of the oropharyngeal musculature. Changes in the soft palate musculature is a known fact. The Malampati score from 2 to changes to 3 to 4, and the higher the Malampati score, the greater is the risk of the OSA. There is a changes in the tongue musculature. We all know that the Friedman tongue portion, the day the patient becomes edentulous, there is a chances of macroplasia is very high because the tongue increases in size both the anterior posteriorly and the mediolaterally. There is changes in the neck diameter. And this is a very important slide which I want to emphasize. There are the main 3 tissue elements which we need to know here. One is the tongue, the soft palate, and the pharyngeal musculature. The dotted arrow marks where we are going to show shows the sites of attachment of the muscular forces which are exerting on the area, which tend to open the key or keep the airway patent. And imagine when the patient is in supine position or is in the rest position of the sleep, this tend to fall. The action of the counteraction of the muscular forces is reduced, and therefore there is a chances of the airway disorder or the obstructive sleep airway in such patients. And also, as the age increases, we also know that tonicity of the oral musculature reduces. This is also one more factor which we need to keep it in mind. And we also know that this is the position or the constructive action of this musculature is position dependent. So coming to the OSA management in the edentulous patient, there are the 4 important aspects. One is the behavioral modification or the sleep posture. You need to advise to reduce the weight and how to sleep posture either in the side or keep changing the position. The patient, if he's comfortable, can use the CPAP machine, which is not very easy to deal with it. And the ultimatum is the surgery, which is again not purview to our lecture aspect. So one important aspect within the physiological limit what we can use is the oral appliances to treat the OSA patient in the edentulous patient. There are lots of sleep studies are the mandatory before taking up to the sleep disorders or the sleep problems, and here the overnight sleep study or the polysomnography is the gold standard, where there is various types, and type 3 is the minimum requirement which we need to assess with the sleep labs when we want to undertake such oral appliances to treat this edentulous patient. Now, in the sleep studies of the edentulous patient, we need to see the 3 things here, or the 3 aspects. What is the effect of the nocturnal wear of the complete denture if is a completely edentulous patient, and the effect of the complete dentures on the pharyngeal airway space? What happens if we give a complete denture, and what happens if there is an increase in the vertical dimension of the pharyngeal airway space? Let us take one by one. The edentulous and its effect on the airway. Katrina Buka, she has done extremely lot of work on she's one of the pioneer of the sleep studies in the prosthodontic aspect. She evaluated 48 subjects for the sleep apnea or the OSA, and she came out with the hypothesis saying that there is a complete tooth loss favors upper airway obstruction during sleeps, which reduces the retropharyngeal space, and therefore it is associated with the obstructive sleep apnea. This is the evidence of her topic. Morrissey et al. In 2011 said that subjects without teeth or the patients without teeth have a higher apnea-hypopnea index and wider tongue than the subjects with teeth. This is again a morphological factor which is bound to happen when the patient becomes edentulous. This is the authority of his work. Domenico et al. Said that cephalometric assessments with and without dentures and the mandibular plane and the hyoid bone distance and the posterior airway space were measured using the cephalometric studies. He said removal of the dentures during the night reduces the anterior-posterior oropharyngeal wall, distance from 10 millimeter to 5 millimeter, that is 50% reduction, while there is no change in the mandibular plane, higher distance, this thing. Similarly, on that aspect of the last Domenico study, we undertook a study in our institution, that is the Army Dental Center Referral and Research at New Delhi, and we did the studies with aim to evaluate supramatrically the effect of complete denture rehabilitation on the upper way dimensions and the position of the hyoid bone, what influence did it have on the oxygen saturation and the degree of sleepiness, daytime sleepiness by overcoming the upper way collapsibility. We took 30 samples. The inclusion criteria were there. Between the patients were between 50 to 70 years, and exclusion criteria was that if the BMI was more than 30 and there should not be any nasal obstruction or the metabolic syndromes. The baseline lateral ceph was done in the natural head portion, and we assessed the minimal airway space, posterior airway space, and the superior airway space, the distance between the hyoid bone to the mandibular plane, and pulse oximetry was used to assess the oxygen saturation, and the Epworth sleepiness scale was used to assess the daytime sleepiness. That the patients were subject to the test with denture and without denture in the span of 6 to 8 weeks. The results were there was no statistical significant difference between the airway spaces, all the three, and there was no association between the oxygen saturation levels and the wearing of the complete dentures. Similarly, after this, we undertook one more study. Since the supplementary studies for the two-dimensional studies, we undertook a three-dimensional studies using the MRI studies in the similar parameters, and we wanted to evaluate the upper way dimension only in the completely edentulous patients to investigate the role of the complete denture with and without increasing the vertical dimension. 15 edentulous patients between the age of 55 to 60 years were taken, and the study in conclusion, we concluded that upper airway dimension is reduced in all aspects, and we recommend that the edentulous patients to wear the complete denture with acceptable vertical dimension to prevent the collapsibility of the upper airway. We also did a review of the literature regarding the obstructive sleep apnea, prosthodontic perspective. Coming to the complete denture and its treatment in the airways, Mayer et al. Did a sort of a gunning splint where the obstruction was there. We wanted to, they increased the vertical dimension to a certain extent so that the pharyngeal wall, the collapsivity of the pharyngeal wall is reduced. Again, Katharina Bucca conducted a study on the asymptomatic edentulous healthy patient, and she also conducted consecutive sets of spirometric tests of 15 minutes apart, one wearing dentures and one without dentures. She, with this study, came into conclusion that edentulism leads to pharyngeal collapse, as I said earlier. Johannes et al. Studied on 72 subjects to investigate the relationship between the breathing and the denture views, and he found a positive correlation between the sleep disorder breathing and a denture use. So he recommended that there is a reduction in the retropharyngeal space associated with the impaired function of the genioglossus and increased upper airway resistance. So he also recommended wearing a complete denture for the edentulous patient to improve the OSA. There is a mandibular advanced splint which was done where there is an increase in the space between that base of the tongue and the posterior pharyngeal wall. So this is one of the case report which has been presented by Dr. Suresh Nair. Piskin et al. Modified the mandibular advancement device. He also attempted to display the bulky masseter muscle to provide more space for the tongue in the completely edentulous patient with the severe OSA, and he found better results with the severe OSA patients too. Santosh Niyogi he also modified the mandibular advancement device with the existing complete denture. He made the advancement of almost around 4 to 5 millimeter and with a vertical clearance of 3 millimeters. And he also found there is an increased in the case report, increased better results in the obstructive sleep apnea patient who is completely edentulous. Priskin again, he did to determine the influence of complete denture and the spirometric parameters in 4 different oral conditions with denture, without denture, only with the lower denture and only with the upper denture. And he came out with the studies that completely edentulous patients or patients with complete denture unfavorably affect the spirometric values. So therefore, he recommended wearing the complete denture or at least one denture at a time to improve the OSA parameters. What about in the partial dentures? There are lots of studies all done on the obstructive sleep apnea and hypotonic syndrome patients, where in 6 patients, Hokema et al. Said that hypopnea index reduced in 5 patients out of 6. Dual laminated snoring reduction appliances with a comfortable protrusive relation has been made by Dennis Flanagan et al. And there's lots of case reports are available, like Julian Turner. He said when there is an insufficient number of teeth, how to where the patient of the OSA patient can be used to increase the posterior airway space. What happens if there is an increased vertical dimension of occlusion and on what is the association in the upper airway? Prachi Gupta from Nagpur has done a review on the role of complete denture and oral appliances, and she concluded that the complete denture fabricated with acceptable and the possible mild increase in vertical dimension of occlusion within acceptability limits of the tissues can minimize the pharyngeal collapsibility, thereby reducing apnea hypothermic incidences. Marcelli again done that, again 60% of protrusion and re-establishing of the oral vertical dimension can reduce the signs and symptoms and provide the good improvement in treating the severe apneic patients in edentulous patient. Chachur, again, he has said that like intraoral devices contribute to the improvement of the quality of sleep. However, he said that they did not significantly improve the polysomnography parameters. Polysomnography parameters, there are 6 to 8 parameters which we do in the type 3 test. Doing the ECG, EEG, the oxygen saturation, there are so many other, the 8 parameters which we take into consideration. So he said that they didn't improve significantly the parameters. So he said that cannot be indicated per se scientifically towards the treatment of the OSAs. Again, Prachi Gupta, she did that in edentulous patient wearing complete dentures having acceptable vertical dimension of occlusion, where they say that posterior airway space were found to be increased. Whereas by using they use the custom-made acrylic jig to increase the values, and they also assess the inspiratory flow rate, which was increased. So in total, they said that by increasing the vertical dimension, we can have a better results on the apneic patients wearing the complete denture or who are the completely edentulous. PC's AJ et al. Again, he did the study on the effect of vertical dimension, and he recommended that the mandibular advancement devices, vertical dimension of occlusion with the minimum airspace and the minimal bite opening may be more conducive and a better compliance of the appliances in the edentulous patients. Lewandowski said that there is a mean reduction of apnea hypopneic index of almost 70% noticed when there is a slight increase in the vertical dimension. So the lots of the evidence shows that mild increase in the vertical dimension has a tremendous effect on the OSA in the completely edentulous cases. Now, in such scenario, what happens whether the patient should wear the complete denture during night? Yes or no? Now, this is the issue now. Katrina Bukas studied that on a single case of the 44-year-old obese man, and 2 polysomnography studies were done on the 2 consecutive nights. And she suggested that the advantages of removing dentures during sleep should be weighed against the worsening of the upper airway collapse. So she recommended that it is better the complete dentures need to be worn. PBT did the study on 20 Edentulous patients, and they came with a recommendation that the dentures should be worn in night. Arisaka, she did the study on the 34 Edentulous patient to investigate whether the complete denture during sleep, what happens to the AHI, and whether there is any change in the oxygen saturation. And they concluded that wearing complete denture during sleep improves AHI for most of the complete denture OSA patients. But they also warned that the risk-benefit ratio need to be weighed before advising the night. Fernanda Almeida, she has done lots of work. She's from the University of British Columbia. She has done many randomized clinical studies to assess whether you need to wear the complete denture during night on what happens to the quality of sleep. In all her studies with the sleep analysis, she said that AHI was significantly higher in mild OSA patients, but the complete denture had no effect on moderate to severe OSA patients. And she concluded that neuromuscular and anatomical factors has a huge and a major role to play more than these sleep appliances. Elam Emami said that he did the 1-year follow-up of 53 patients using the qualitative analysis of the Pittsburgh Sleep Quality Index and the Epworth Sleepiness Scale evaluation. And they said that the complete denture using complete denture during sleep has a little or a no effect on the daytime sleepiness. So the debate continues whether to remove the complete denture or to wear the complete denture during night. We need to assess what is the mucosal reaction, what about the residual resorption pattern of the patient, and how much of the enigmatic increase in the AHI ratio is there, whether there is an increase in the oxygen saturation, there is an increase in the upper airway space, and by using the factor need to be balanced, assessed, and the pros and cons should be assessed, and then we need to advise the patient regarding to wear or not wear the complete denture during sleep. There are lots of unresolved issues which are there, where there is a concomitant bite opening with the mandibular advancement, especially with the partially edentulous patients. And what about the role of complete denture, which we have just discussed? What happens to the increase in the vertical dimension? I have always given you the concrete evidence-based studies. What happens? What happens to the implant-retained mandibular reposting appliances? What is the effect of the appliances on the implant, the bone loss, and the survival factor of the implant need to be assessed. We are still, majority of the cases have been used the two-dimensional cephalometric study. Assessment need to be done to come into a concrete changes what happens during sleep. Although the oral appliance therapy are the conservative and non-invasive treatment option, they can be tried, but with or without vertical dimension. In case of the partially edentulous patient, we can also use the tongue repositioning appliances can be utilized. What happens to the modifications we need to see? The oral appliances in the partial edentulous patient, completely edentulous patient, and the implant supported this thing. What I have already discussed. Disorders are now getting into the curriculum, and I personally feel that this should be a part of the curriculum in our MDS prosthetic curriculum. Oral appliances therapy in totally edentular sleep apneics. We need to long-term potential complications we need to see. What are the types of number of teeth remaining and whether their diseases, or whether there's teeth mobility need to be checked. Is there only the placebo effects are used? What happens with the fixed or the removable type? And as I told earlier, what happens to the implant-supported oral appliances? There are lots of future perspective in the sleep. This is the happening or the contemporary issues. There are lots of genetic studies which are coming, whether is there any genetic therapy can be used to prevent the sleep disorders? Because even in the pediatric sleep disorders are on an rise, and lots of pediatric, in fact, in our institution, we have taken up the sleep studies on the pediatric patients. What happens to the completely edentulous patients, their OSA risk? We need to screen virtually all the edentulous patients coming to the institutes with the portable devices. And we need to do lots of the MRI studies or the 3D imaging studies with or without the complete denture to come to a long-term effect of the complete denture. The longitudinal prospective studies are a must. What about the pharmacotherapy? It is not that why in case if the severe apneas are there, what it is on which there is no effect of the oral appliances. The pharmacotherapy can be utilized here. There are lots of drugs that people have started using nowadays now with the respiratory pulmonologist in association, which I'm going to tell you in the next slide. There are lots of biomarker studies have been used to assess the sleep apnea patient. Like, as I said, review of the biomarkers, the serotonin or the 5-HT, the neurotransmitter or the neuromodulator, reduction in 5-HT or serotonin worsens the OSA has been found, and the drugs like the agonist drugs for the 5-HT or the serotonin, like mirtazapine, fluoxetine, are used to treat the OSA, which are not the central apneics. These are the biomarkers in the obstructive sleep apnea by Lipford. Tripathi et al. Has also done a study on 381 completely edentulous patients, which we found out that there is an incidence of almost 40% of the patients in our Indian scenario who are having the obstructive sleep apnea. And he also found a correlation between the OSA and the serotonin, and he recommends that using the serotonin in the seeing it as a biomarker or a diagnostic marker can be used by the blood investigation. This is the evidence-based. The cysteine and the homocysteine, although they are the factors to recognize the cardiovascular diseases, they also has a potential biomarker. The use can be used as a potential biomarker for the obstructive sleep apneas. Proteomic biomarkers are the latest in the field, and the latest article says that they say that blood serum assess or the proteomic assess say that there's almost 65 proteins which are prudently seen modulating the central apnea, where in ROBO3 and the cystatin F proteins are assessed. Now, in case of central apnea, this also can be used to assess whether to know whether the proteomic enzymes assay, whether to differentiate between whether it is a central apneic or a peripheral apneic or a mixed apneic. So central apneic, the only drug or the surgery is the only option. Drug therapy is the only option, not even surgical labs. Only the obstructive sleep apnea where the dentistry or the prosthodontic role can be seen. In our institute, we also said that what about the children who had a pre-surgical nasal or molding with the cleft palate and lip? What about their airway dimensions? The retrospective study was continued for almost 12 years since we did the nasal molding the patients, and we found that the patients who have undergone the nasal molding during infancy have a better improvement in the nasal and the upper airway patency compared to those cleft palate and patients who have not undergone the NAM procedures. So the airway patency, which can be seen from the childhood, especially when the cleft palate and the lip patients. So to conclude, we need to be more increase in the awareness for the edentulous patient, and all the completely edentulous patients need to be screened for the OSA with the portable assessment, and home studies can be done with the portable equipment to assess the sleep apnea. When in doubt, we can always go for the PhD studies with the sleep lab. Also, there is the literature evidence. What we just concluded, that we said that there is evidence of increasing the vertical dimension, but we need to assess the risk benefit factor, whether we need to increase or we need to maintain or we need to moderately increase the vertical dimension to have a better effect on the sleep apnea in the completely edentulous patient. Whereas in the partial edentulous, we can use the removable appliances, or you can use the titrable appliances in case of the partial edentulism. And all the pros and cons regarding the health of the tissues, health of the TMJ, and the acceptance factor of the patient should be taken into consideration regarding the treatment or the risk of the collapsibility of the airway. The pros and cons of the nocturnal wear should also need to be assessed before we recommend the wearing the nocturnal this thing. Well, gentlemen, thank you for your patient hearing. I end my talk with the quote: the more you know, the more you realize how much you don't know. And the less you know, the more you think you know. Thank you, ladies and gentlemen. Thank you so much. Any doubts, any question, either you people can email me or you can ask me now.
Thank you, sir.
Thank you.
Thank you for such an enlightening session. I hope we all have learned a lot from it.
Thank you, Dr. Mahesh Gowda, for wonderful and informative lecture. You have shared depth knowledge in correlation between edentulism and obstructive sleep apnea with evidence-based study. It will be helpful for all participants. Thank you, Doctor.
Dr. Maninder, it is muted. Yeah.
Thank you for pointing it out, sir. I just wanted to express my heartfelt thanks and gratitude to you. It's been a pleasure, as always, hearing you. And thank you for enlightening us on the topic. I'm sure each one of us has come across such patients in our day-to-day practice, and we've always been left baffled as to what to do. Should we not? What kind of an appliance? So your lecture has given us a lot of ideas. You've brought it all together very well, and I'm sure it's been of use to each one of us. Thank you so very much, sir.
You're welcome. Thank you.
I now hand it over to the organizing committee to please give away the certificate of appreciation for Brigadier Gowda.
Yes, ma'am. Thanks a lot for your valuable time, everyone. Please accept this token of appreciation from our side.
Thank you, organizing committee.
Welcome, ma'am.